I hope this is live classes. That's already going recorded. We have notes and MCQs also here. And also we have this few packages or subscription plans. We'll start from the basic plan over here and we go up till the mentorship plan. The basic plan is around 3 months and mentorship goes around 12 months, and between we have a 6-month plan as well. And the subscription prices range from 15K to 30 and goes up till the 50K. That is for the 1 year complete. In this mentorship plan, what extra you get is all the notes, and also one-to-one personalized guidance is also will be provided, particularly because it's a long duration, 1 year, so that will obviously be needed. So you can also book a slot for personalized counseling session, right? And can below you can use this code also, guys. Don't forget to use this code if you're planning for any subscription. Do go with the subscription. You get a good quality of lectures over here, good amount of notes over here, as well as your personalized counseling, okay, and recorded classes too as well. So let's start the session over here, and as discussed, let's do with this our gluteal region over here, right? So this is what we are going to start with today. So let's begin now. Here is the topic, that is a gluteal region. A gluteal region is obviously present in also known as the buttock region. Sometimes as a non-medical, people used to think that this is a part of the abdomen or pelvis, but no, gluteal region is actually the part of our lower limb. Gluteal region is part of lower limb. So important questions from here. The name gluteal region, so the major muscles over here are named as gluteals. Yeah, so we have glutes, so known as gluteus maximus, then gluteus medius we have, then gluteus minimus we have, and other small muscles are also there. We'll see further on. Those small muscles basically are the lateral rotators of thigh. So let's start the gluteus maximus. The questions normally can come are tell us about the complete information about the gluteus maximus, and also they can ask what are the structures which are under cover of the gluteus maximus muscle. Okay, so as we've discussed already a number of times, that whenever a question comes for any muscle, you have to do these 4 or 5 things mandatory are: discuss the origin of the muscle, discuss the insertion of the muscle, which nerve is going to supply it, and what is the major action of it. And if additional, you can write about blood supply, not bad about it, right? So yes, gluteus maximus is the huge muscle present in the gluteal region. Where does it take origin? It basically takes origin from the sacrum, coccyx, and around the iliac crest. So you can see over here the ilium, sacrum, they all contribute, and the sacrotuberous ligament. They all contribute to the origin of the muscle. Where does it insert? When we discussed in the previous session about the deep fascia, we discussed about the iliotibial tract. Okay, the modification of deep fascia. In that we discussed that it also helps in insertion of the gluteus maximus, majority of the gluteus maximus. So you can see over here that insertion goes to the iliotibial tract and also to the gluteal tuberosity. Over here, do remember the maximum part, 3/4 of the muscle goes into the iliotibial tract, and around whatever is left, 1/4, that goes into this greater gluteal tuberosity. Okay. Next, nerve supply, it is supplied with the inferior gluteal nerve. Now it has root value of L5 to S2. So you can say that this nerve is coming from the lumbosacral plexus. Action. Now, action is very important. This is what the action is very important, because clinically also it's very important. It basically helps in extension of the thigh, or you can say extension of the hip joint. Now let me tell you over here. Now when you're sitting on a chair, suppose there's a chair over here. So when you're sitting on a chair, suppose there's a head region, the trunk region, then you have the thigh region and the leg region with the foot over here. So we all can understand that this region is the hip joint. Putting an arrow over this region is hip joint. In sitting posture, our hip joints are basically flexed. So what is the action of gluteus maximus? Action is that suppose this is the whole lower limb, you are seeing the sideways. So movement of the whole lower limb posteriorly back. This action is the extension of the hip joint or extension of the thigh. That is done by the gluteus maximus muscle, and you can imagine that this muscle is the majority of the bulk of the buttock over here. So when this muscle will contract, it's going to pull the lower limb posteriorly. Okay, that is why the main action is that it helps in what? It helps in extension of the thigh and assist in adduction and lateral rotation as well. Is assist, but remember, major action is extension of the thigh. Okay, then blood supply comes from the superior inferior. This muscle is important, so I discuss a bit of detail and try to understand the action. See, when you're sitting in a chair, when someone asks you to stand up, if a person is able to stand up unassisted without the use of any help here and there, the person is able to stand up from a sitting position unassisted. That means the gluteus maximus muscle is working fine. That is simple, right? Then if you come below, the other muscles around it after gluteus maximus, other major important muscle over here are these two muscles, gluteus medius and minimus. Just remember over here, they have all the things written over here. Then where do they take origin from? Where do they insert, right? And what is their nerve supply? What is their main action? These are obviously important, and the blood supply as well. Now, gluteus medius and minimus, just to summarize, as you can see in the notes, you can take the screenshot if you wish to. But do remember over here that these two muscles are basically present on the lateral aspect. Lateral, that is on the outside. Therefore, their major action will be what? Their major action will be abducting the thigh. Their major action will be abducting the thigh. That is will be the major action. That is, if you take the lower limb out from the away from the midline, that is known as abduction, abduction. Their major action is abduction. And that is very, very important while what? While walking. As you will see later on, while walking, this action is very, very important. Therefore, the nerve supply for these two muscles is same as the superior gluteal nerve over here. Remember, for the maximus, it was inferior gluteal nerve. Look over here. And for the medius minimus, it is the superior gluteal nerve. Why this nerve is so important? Because see, as this muscle or these muscles are helping in walking. So if there is a palsy of the superior gluteal nerve, there will be problem in walking, as you will see later on. We'll discuss waddling gait, lurching gait, and the Trendelenburg sign. Because this nerve is important. Then you can see both of them are inserting where, that will also come as a question. They are both going basically into the sides. So greater trochanter is present where? It is present on the lateral side. Okay. Then we have these three muscles are most important, gluteal region and three gluteal muscles. Then we have some smaller muscles. Okay. You can see over here, we have the piriformis over here. We have the obturator internus over here. Sometimes if you are going through all of my lectures, you might confuse the obturator internus. We have obturator, we have heard somewhere. Yes, you have heard yesterday only, but that was obturator externus in the previous session. This obturator externus, guys, was the muscle of the medial or the adductor compartment of thigh. And its nerve supply was coming from obturator nerve. But this muscle over here now is obturator internus. And its nerve comes directly from the plexus, that is nerve to obturator internus. And piriformis by S1, S2. Now, all of these muscles, let me just go through piriformis, obturator internus, then we have superior inferior gemelli, we have quadratus femoris, these major 5 muscles over here. Okay, their main action is what? Their main action, they are known as small lateral rotators. You can see all these 3, 4, 5 muscles, their major action is the lateral rotate of the thigh. Lateral rotation means obviously rotating outside. Now, sir, that is good while writing, but understand where this action is practically used. This action is practically used where, let me just try to show you. See, suppose this is you're sitting in a car. Imagine you're sitting in a car, right? And suppose you can make like, say, there's a window of the car, that is a whole say door of the car, and okay, just imagine this is a car, right? And you're sitting over here, you open the door, and the person is coming out of the car. Now the person is coming out of the car. Once the person is coming out of the car, what? Just imagine what part of the body first comes out of the car is the lower limb. And what do? You laterally rotate the lower limb, right? So once a person is coming out of the car, the first major action is your lateral rotation. That is your lateral rotation of the lower limb. That is done by these small lateral rotators, which are those, at least remember the 5 names: piriformis, obturator internus, superior inferior gemelli, and your quadratus femoris. Okay. So that is a major action. And original insertion, they have smalls. Yes, you may remember them. That helps in drive also. So these are your 5 small lateral rotators. It's written also over here. You have these major 5: piriformis, obturator internus, superior inferior gemelli, 1, 2, 3, 4, 5. Okay, and one more. This is repeated, right? So 1, 2, 3, 4, and there's the 5th one, quadratus femoris. So these 5, remember, these 5 are lateral rotators of the thigh. Normally, they are directly supplied by the branches of the lumbosacral plexus. Okay, lumbosacral plexus. Do remember this. So yeah, 5 and 3, 8 muscles we already have sort of covered. Now, the other question in theory that might come is, what are the structures under cover of gluteus maximus? Now, you might think that sort of why they are asking this question. Who will remember this? See, you might understand its major importance right now in the first year if you're giving the exam, but understand the moment you go for surgery, the moment you become a surgeon, you make an incision from the skin and fascia, you retract the flaps of the skin fascia, then you have the gluteus maximus muscle. Now this muscle is huge. Now if you have to deeply enter deep to the gluteus maximus, obviously you have to retract the muscle. You have to take instruments deep to the muscle. Now, if you don't know what exactly lie deep to this muscle, then obviously it will be very risky proposition, right? It will be risky. You don't know you're cutting which artery of which nerve, which muscle is there. Therefore, it's important that as a surgeon think that once we are reflecting the muscle, what are the structures which I can anticipate, which are deep to this structure? That is why this question is important. That is why you need to know it, right? Now, so the structure of the gluteus maximus, you can divide it if you're writing in the exam. There are few muscles, okay? Point number one. Then there are few vessels, okay? Muscles, vessels, and obviously if muscles are there, you need nerves. So see, if muscles are doing their job, muscles need two main things: nerves and blood vessels. So if muscles are there, obviously there will be nerves and blood vessels. That's mandatory. So these three things will go right. Then more deep, if you go, you will find some bones, joints, and as well as some ligaments. If the joints are there, then there's also going to be bursa over there. So just remember two major things: that there are muscles, related structures, and there are joints and related structures. So when you think of muscles and related, you automatically think of nerves and vessels. When you think of joints and related structures, you always think of, okay, joints are there, there will be capsule, there will be ligaments, obviously bones are there, which are from the joints. Okay, so just remember two things: the structures on the cover of gluteus maximus. The question comes in your mind should run two things, okay, that there are muscles deep to it, and as I go more deeper, I am going to find some joints. Basically, you have the hip joint over there. So you understand that why this question becomes more important, because hip joint surgeries are so common, right? Hip replacements, okay? Total hip replacement, all the surgeries around the hip joint. You have avascular necrosis, you are replacing the head of femur and all that. No. So what are the muscles over here which you can find below or deep to the gluteus maximus? Obviously, as you can see over here, a lot of muscles. Basically, medius, minimus, piriformis, all these names that you have heard till now, they're all there. Except, extra, you can add over here the reflected head of rectus femoris. Now, this muscle rectus femoris, you have heard it where? You have heard it in the quadriceps femoris. Where is quadriceps femoris? It is present in the anterior thigh compartment. But this is not the entire rectus femoris, it is a reflected head. So this reflected head actually comes from above the acetabulum. Suppose you have this acetabulum, right, where you have the socket of the hip joint. This reflected head is coming from here, then it is going down, okay, then it is merging with the straight head, and they are forming the muscle rectus femoris. So as this reflected head over here, is present above the acetabulum, above the joint. So we know that deep to gluteus maximus, we will have this joint. So we have this muscle as well. Just in a way, I'm going to tell you a bit in detail. That's it. So you have this muscle. Then you have origin of four hamstrings of ischial tuberosity. You have basically ischial tuberosity deep to the gluteus maximus. Ischial tuberosity will give rise to the hamstrings. So origin of hamstrings will be there. Insertion of some adductor magnets. But do remember to write at least these 7 muscles. What 7 muscles? Total we learned 8 muscles, 3 glutes and 5 lateral rotators. So total 8 are there. Now they're asking you deep to gluteus maximus, at least write these 7 muscles. Then you should write about the reflected head of rectus femoris. You can even write about the obturator externus as well, which was a muscle for the your adductor compartment of thigh. Okay. Now if you have learned about this, you can write the majority of the muscles over here, then the vessels. Obviously, vessels, you can write about the gluteal vessels over here to begin with. Then you have internal pudendal vessels. As you will see, the structures passing through the sciatic foramen, these pudendal vessels will come, because they supply the perineum. And we'll talk of these anastomosis also. Why? Because these anastomosis are supplying the hip joint, the bones, right? So just to make you understand, you start with the gluteal vessels. This vessel is going to supply the area for perineum, and this is for the hip joint. These vessels supplying basically the hip joint. So these vessels you can write, and as you know the muscles, then you can write about the nerves as well. As you have seen, superior gluteal nerve was supplying which muscles? So gluteus medius and minimus. Inferior gluteal was supplying gluteus maximus. Then think about the lumbosacral plexus. Lumbosacral plexus. Lumbosacral plexus was giving a lot of nerves, right? Lumbosacral plexus, L5, S1, S2, S3, they were giving a lot of nerves, except for the, say, the obturator nerve, because we have learned the course that lies inside the pelvis. Except for the obturator nerve, most of the nerves which you see from sciatic to pudendal to obturator to perforating cutaneous, all will pass deep to gluteus maximus. So let me just point out over here that lumbosacral plexus minus, you can think of obturator nerve. Why? Because obturator nerve was running inside the pelvic cavity. It didn't went outside the pelvis through the sciatic foramen. It went outside the pelvis through the obturator canal. Then it went straight away to the medial side of thigh. So under cover of gluteus maximus, you won't find obturator nerve. Think about it. Bones and joints, as we already said, remember this word over here, that is self-sufficient, is a hip joint. Okay. And as the muscle took origin from the sacrum and iliac, so there will be sacroiliac joint, there is going to be sacrum coccyx, there is going to be ilium, there is going to be ischial tuberosity. We saw that the hamstring's origin was there. So you have ischial tuberosity, you have the femur gated trochanter as well. So in bones and joints, you will have related ligaments over here, and you will obviously have the related bursa over there, right? Why bursa? Why see? What is bursa? Bursa is there to reduce the friction. So what happens is whenever there's a major joint, major synovial joint, particularly, so whenever there's a major synovial joint, there are going to be a lot of tendons and ligaments which are around the joint. And whenever you move the joint, obviously tendons will obviously pull. That is why the muscle is acting like this only. So when the tendon is pulling, then that tendon, which is very strong, might damage the bones over there, right, at the joint area. So to prevent the friction, we have the bursa. Okay, so whenever you have joints, you have bursa. So you have ligaments, you have the bones, you have the muscles, vessels, and now just go through this 2 or 3 times, you will good to. That is what structure deep to gluteus maximus, a question frequently asked. Then they might ask you structure deep to gluteus medius or structure deep to gluteus minimus. Let's go through them once or twice, things will be easy. Now we are going more deeper. Now structure deep to gluteus medius will be what? Will be its nerve supply, will be its the muscle which is more smaller muscle, and also its artery. Okay, so they're asking about the gluteus medius. Think of its nerve supply, think of its blood supply, right? 2 points are like this, and it is medius, and think of minimus, which is also lying, and deep you can say about the bursa as well, these 4 points. Then they ask you about the minimus. Minimus is now more deeper. So you are coming close to the joint. Suppose someone asks you, how do you approach the hip joint? Through gluteus maximus. Okay, then obviously you have to retract the maximus, medius, and minimus. Okay, then these are the structures deep to gluteus minimus. Just a second, right? Okay, right. So these are the structures which can be asked as a question. Mainly, it is the maximus which they ask, but a medius minimus can. Okay, moving ahead from here. Now, what are the structures that pass through the sciatic foramen? Very, very important question over here. Sciatic foramen, we have 2 sciatic foramens. Basically, we have a greater sciatic foramen and we have a lesser sciatic foramen. Where do we see them? We see them during on the hip bone. Remember in your DH or bone section, when the hip bone was handed over to you to just go through it. How do you handle, or how do you pick up the hip bone? You handle it like something you handle between your first rib space. So that concavity in which you put your hand to hold the hip bone, that concavity is the greater sciatic foramen. Okay, so what we have actually the greater sciatic foramen. Then we have a very small foramen over here. Obviously, you can't put your hand inside this concavity, but yeah, you have a lesser sciatic foramen, and between them you have this thing over here that is known as this very small ischial spine. So now they're asking, what are the structures that are passing through these foramens? What you normally see in bone are not foramens. What you normally see in bone are known as notches, greater sciatic notch and lesser sciatic notch. What then happens is you have the sacroiliac ligament, you have the sacrotuberous ligament. Now these ligaments, they convert the notches into foramens. That is the whole point. So now this is not a notch. It is basically what? It is basically a foramen. They are basically foramens, and structures will actually pass through them. That is what you have to understand. So remember, greater sciatic foramen is above, and then you have the lesser sciatic foramen. Where would it be present? As the name is sciatic. Sciatic nerve is coming from sacral plexus. The plexus are coming from where? From the spinal cord. Where is the spinal cord? Is it present anteriorly in the body or posteriorly? Posteriorly. Okay, so spinal cord is in the vertebrae are posteriorly. Therefore, these notches, as their name are related to the sciatic, these notches or foramens are present where? They are present posteriorly. That is the basic logical sense that you can use that. Okay, so we have a bigger, greater sciatic foramen. Now, in this bigger, greater sciatic foramen, let me tell you one more thing over here. The major content of this greater sciatic foramen and the major content of the lesser sciatic foramen are basically 2 muscle tendons. I repeat myself, the major content of this greater sciatic foramen and the major content of the lesser sciatic foramen are two major muscles. What are those two muscles? This muscle you have heard from the greater sciatic foramen is a piriformis. It is a piriformis. And the tendon that is coming out from the lesser sciatic foramen, it is a tendon of obturator internus. Obturator internus. This thing do remember. So through the greater sciatic foramen, you can say the key muscle. You can say the key muscle of the entire gluteal region is piriformis. Like we discussed, the key muscle in axilla was pectoralis minor. Similarly, here in the key muscle in the gluteal region is piriformis, and then lesser sciatic foramen we have the tendon of obturator internus. That's it. Okay. Now let us see over here structures passing through greater sciatic foramen. So as the key muscle is piriformis, they have decided to answer it through above piriformis which structures to pass, and below piriformis what structures will pass. So above piriformis you can see you have superior gluteal nerve and a vessel. Simple. Above piriformis, superior gluteal nerve and vessels. So obviously over here you can understand that above piriformis you will have the superior gluteal artery and you will have the superior gluteal nerve coming out. Then you will have huge piriformis, and after that you will have all of these structures which are running below piriformis. These are all the structures which are running below piriformis. Inferior gluteal nerve and vessels, then all these nerves coming from the lumbosacral plexus, and finally you have the internal pudendal vessels. Sometimes you might be wondering that, sir, where does this internal pudendal vessel actually come from? The question might come to your mind. See, this vessel is coming from the internal, it's a branch of internal iliac artery. It's a branch of internal iliac artery. What does this vessel do? What area it supplies in gluteal region? It does not supply any area in gluteal region. The answer why it is over here? Tell me. So see this pudendal nerve over here and this internal pudendal vessel, they are not supplying gluteal region, but they only pass through greater sciatic foramen so that they can later on pass through the lesser sciatic foramen such that these both structures can come into the region of the perineum. That is the whole point. So the nerve of perineum is pudendal nerve. The artery of perineum is internal pudendal artery, and the vein is internal pudendal vein. I repeat myself. Hear it. You have the key muscle piriformis. You have a couple of structures going above piriformis, and you have a lot of structures coming below piriformis. Out of them, one of the major structure over here is your sciatic nerve as well. The sciatic nerve comes below piriformis. But then you have other two structures known as pudendal nerve and internal pudendal vessels. You might think, what are they doing over here? They are nothing doing over here, but what they do is they then later on pass through the lesser sciatic foramen. You can see these two structures to enter into perineum. So you have through lesser sciatic foramen these two structures, and then you have that obturator internus tendon, nerve supply of the tendon, because the tendon was the bulk of the lesser sciatic foramen. So in lesser sciatic foramen, what we had in lesser sciatic foramen, we had the tendon of obturator internus, as I already told over here. So therefore, the nerve supplying it should be there, and there it is. So this is what we call as pin structures. PIN. PIN is pudendal nerve, internal pudendal, and nerve to obturator internus. Pin structures. And out of this PIN, remember, these PIN are also there where in the greater. So this from this greater sciatic foramen, the pin structures will be there, and they go from greater to lesser sciatic foramen. I hope you're getting a point. You see the images, you'll get a good idea of it. See, this over here is the posterior view. Okay, so you can see over here the pin structures, how they're passing through the lesser sciatic foramen, and this huge muscle over here, this will be the P for piriformis. This will be P for piriformis. So remember the pin structures. This is a very favorite question, and pin structures do come in exam. And one more point, as I already told you, I'm just telling you again, don't forget that the sciatic nerve is where it is below the piriformis. Why I'm saying this? Because applied part also you are going to discuss. The sciatic nerve might be compressed because sometimes it might pass between the muscle fibers of piriformis. So the moment you are, the piriformis muscle is contracted, this sciatic nerve will be compressed, can lead to pain. That is known as piriformis entrapment syndrome. Applied part I'm telling you over here, that is known as piriformis entrapment syndrome, where piriformis entraps the sciatic nerve, leading to a similar pain like that of sciatica. Right? Okay, so structures passing through greater lesser sciatic foramen. It's an important point over here. And see, you can make a diagrams over here. The key muscle. Let's see that too over here. Okay. So exit only through greater sciatic foramen. Only through greater sciatic foramen. Okay. So then exit only through lesser sciatic foramen. Here, what they have missed out, they have not specifically named pin structures because they are passing both from greater and lesser sciatic foramen. The question can be in different ways. Just understand that pin structures, they pass through both the greater and lesser sciatic foramen. This is what the whole point is. Okay, as we go ahead now. Yes, now we come to that anastomosis thing. We discussed that structures deep to gluteus maximus. We said two things, muscles and joints. For muscles, we said we have nerves and vessels. In vessels, we discussed there that we have some trochanteric as well as some anastomosis, like cruciate anastomosis also might be found deep to the maximus. So what are these anastomosis? Let's understand. So trochanteric anastomosis situated near the trochanteric fossa. If you look at the bone of femur, you'll have a head of femur, then you'll have a neck, you'll have greater trochanter over here, you have a small, lesser trochanter over here. Here, somewhat over here lies the trochanteric fossa. Trochanteric fossa, and there you have a vascular anastomosis near the trochanteric fossa, which supplies the around the region of head of femur. That is what trochanteric anastomosis is. Now the question comes that, okay, which vessels they contribute to the formation of the trochanteric anastomosis? What are the vessels which are going to contribute for the trochanteric anastomosis? That's going to supply the head of femur. That's important. Let's see it. Here is a simple image that is made. Trochanteric anastomosis, you have one branch coming from above, that is superior gluteal artery. You have one branch coming from the sides, that is the inferior gluteal artery. Then you have one branch coming as a medial circumflex, one branch coming as a lateral circumflex femoral artery. Now, see, understand the trick over here. The trick over here is that if you look at medial and the lateral circumflex femoral artery, both of these are branches of profunda femoris, remember? Which was a branch of what? Which was a branch of femoral artery, remember? And this femoral artery was a continuation of which artery? Femoral artery was a continuation of external iliac artery. Okay, so you have these two branches coming from external iliac artery. Now, if you look at the superior and inferior gluteal artery, think these are branches of which artery? The superior and the inferior gluteal artery, they will be branches of which artery? They will be basically branches of the internal iliac artery. Okay, so basically over here, in the form of anastomosis, we are having anastomosis between the branches of external and internal iliac artery. What's the point? Point over here is, suppose there is damage to one particular artery or there is compression to one particular artery, there is atherosclerosis to one particular artery, other artery might help to supply the blood to the head of it. That's the whole point. Okay, so this is trochanteric anastomosis. There one more anastomosis. Look at the diagram over here. So this is a specific location, the approximate, not approximate location, this is the area where the trochanteric anastomosis will be there from these different branches. Okay, so we have external iliac branches as well as internal iliac branches. Supplying the head of femur. Then apart from the trochanteric anastomosis, we have one more anastomosis that is known as our cruciate anastomosis. Cruciate means cross-like. First point that comes to our mind, okay, where this anastomosis is actually present. This is present where? At the level of middle of the lesser trochanter. It is present slightly at a lower position than the trochanteric anastomosis, slightly. Cruciate anastomosis. Now, who is helping the formation of cruciate anastomosis? How to remember it? See, in trochanteric anastomosis, what we said, okay, we have a superior gluteal artery, we have an inferior gluteal artery, we have a medial circumflex, we have a lateral circumflex artery. In case of trochanteric anastomosis, in case of cruciate anastomosis, forget about the superior gluteal artery. You will have an inferior gluteal artery only. You will have both medial circumflex and lateral circumflex femoral artery. And which will be the fourth one? Fourth one will be basically branch of profunda femoris, the first perforator. As we discussed in the previous session, if you have not gone through, then please go through. That profunda femoris is a deep branch of brachial, is a deep branch of femoral artery, and it gives off the four perforating. They will perforate through the adductor muscles, and they reach the posterior thigh compartment. From there, the first perforator will give the ascending branch that will form the cruciate anastomosis. Now go through this. From above, what happens is we have the inferior gluteal artery branch. From below, see what happens. You have the branch from the first perforating artery. From sides, you have transverse branches of medial circumflex and transverse branches of, so these remain over there and they form the cruciate anastomosis. So again, if you look at the vessels, if we talk of vessels over here, all of these three, they are coming from where? They are basically continuation of branches of the external iliac, while this is the branch of internal iliac. Again, the same thing applies. Okay, and this will be a major contributor. Look at the location of the cruciate. This is the location of the cruciate anastomosis. Can you see this circle over here? Right, and from here, the branches, they go and supply the obviously the hip joint and the head of femur. So cruciate anastomosis over here again. You can see if you know the theory, guys. If you know the theory, you can make upper end of femur and you can make diagrams. This is how you can score in exams. Okay, and you can ask, you can write the applied part. Okay, that if this artery is damaged, then that might happen. There can be vascular necrosis of the head. This is very important. Care should be taken while doing surgery over the hip region, while doing total hip replacement to maintain these arteries. They form the anastomosis. And suppose someone is not aware of the anastomosis location, and someone is doing surgery, giving incision in that area. They are going deep and deep. And one small cut, you can damage 2, 3 vessels in one go. Just imagine. So if you are aware, okay, the anastomosis lies over there, you know that again, a lot of vessels are deep to the structure. Your approach will be obviously quite different from the approach if you don't have any knowledge of it. That is where the anatomy comes into play. Okay, fair enough. Now, actions and effect of paralysis of gluteus medius and minimus. As I said in the beginning, in the first part that as you will start the gluteal region, I said the gluteal region, gluteus maximus, medius minimus. In maximus, we said one word. I told you one word for the action of the maximus. What was that? For maximus, I said, okay, extension of thigh. Once you stand up from sitting position, this will be the action of maximus. And for medius minimus, the main action of medius minimus was abduction of thigh. Abduction of thigh, helpful in walking. So see over this is how you can write about the clinical anatomy if you have the basic knowledge, as simple as that. Things become very simple. How to test gluteus maximus? Okay, try if you know the action of any muscle, ask the patient to do that action against resistance. Simple as that. You don't have to cram anything. You just have to apply common logical sense, which you guys have a lot. If they ask to test any muscle, if you know the action of that muscle, okay, try to ask the patient to do that action, but do remember against resistance. Against resistance. This is very important. Against resistance. For example, let me give you an example. Why is this important? Suppose the muscles which are adducting the arm. What are the muscles adducting the arm? They are pectoralis major. Okay, they are in fact they are teres major also. Okay, even latissimus dorsi, they all adduct the upper limb. So if you ask the patient, okay, adduct the upper limb, a patient will do this, and okay, he will do this, okay, adduction. But this adduction is actually aided by gravity. Okay, it is automatically done. So what you need to do is you need to put some resistance and then ask the patient to adduct and then feel the power of the muscle. Similarly, for any action, you have to do this thing, right? So you can test the gluteus maximus, you can test the gluteus maximus paralysis. If it occurs, what will happen? These things patient might come and say to you directly. Patient cannot stand up from a sitting posture without support. Another thing over here is that walking up the stairs, going upstairs. When you go upstairs, you flex your thigh and you put your foot on the next step. Then what you do, you lift your whole body. And your thigh goes from flexion to extension. Therefore, remember, apart from this, walking upstairs is a very, very good exercise if you want to exercise your gluteus maximus. If you want to test the gluteus maximus, just ask any person to walk upstairs. In one step, you will be able to understand. Okay. Okay, now test for gluteus medius and minimus. Test for gluteus minimus, basically, the question comes as in the form of this here, lurching it, waddling it. And over here, we have what? We have the Trendelenburg sign. Okay, read about the lurching and waddling it. This is all you can the clinical anatomy. Above, I have left, but don't worry. The question will come of IM injections. Intramuscular injections are given, obviously. We all know there are 2, 3 favorite sites. One is the deltoid region, one is this gluteal region, and one in small children, infants, they occur anterolateral part of the thigh. These areas, the IM injections are normally given. So when the IM injection is given the gluteal region, if this image, or if you look over here in this image, this is the injection over here, right? It is given in the which quadrant? It is given in the superior lateral quadrant, or you can say in anterior superior quadrant. Okay, or you can anterior superior is like similar to superior lateral. Superior lateral over here is moving anteriorly. This area is going anteriorly. So you can say superior lateral quadrant. The muscle into which the drug actually enters, once you do an iron injection, you push the drug. The muscle into which it normally enters is your gluteus medius, and if it goes a bit deep, it will be gluteus minimus. Okay, this thing you remember. Now come to that waddling gait or lurching gait. So when gluteus minimus and medius are paralyzed, patient cannot walk normally and bends or waddles on right side. See, guys, if you are not aware, then try to walk. Try to walk and see. Or if someone is walking, try to see their walk and see how their lower limb is what action is the lower limb doing? You'll understand that part. Here we let me discuss with you the Trendelenburg sign over here. Now see, just look at this figure, you'll understand. Now be with me for the next few seconds to understand this part. So what happens is, in this particular condition over here, the right foot of the patient is on the ground, right? The right foot of the patient is on the ground. When the right foot of the patient is on the ground, and the patient is lifting the left foot for walking, which is the unsupported side. The left side is unsupported side. This is the left side. That is the right side. The left side is unsupported side. Normally, what should have happened is that when this unsupported side is over there, then with the weight of the body, this side of pelvis should go down. That should have normally been occurred. Agreed? But what happens actually is that when the person takes the left foot off the ground, okay, the right foot, which is on the ground, that side, gluteus medius and minimus, they contract. And once they contract, what they do is, they're obviously going to pull the pelvis to their direction. So now see what happens is that the gravity, I'm writing G over here, was pulling the left half of pelvis down. But these muscles over here, they are pulling the pelvis to their side. So such that what happens is the left-sided pelvis finally, it slightly ascends, so you can lift the left foot off the ground easily and you can walk. You're getting a point. This is how normally gluteus medius minimus works. Imagine. Now in the next scenario, what happens in this image over here? The right side gluteus minimus and medius, they are paralyzed. Imagine. Which nerve was supplying them, if I may ask you? It was the superior gluteal nerve, which was innervating these muscles. Now, if this muscle is paralyzed, so once your right foot, the patient's right foot is on the ground and the right side muscles are paralyzed, and obviously this pull over here is now not working. So therefore, the unsupported side pelvis will go down. The person's pelvis will tilt on one side. Now, if you're not aware of these situations, you might answer in the viva or in the exam that, okay, this side pelvis is going now, this side there is palsy. You might think that this side there's palsy, but no, palsy is on the supported side. So it's a normal side of pelvis that is going down. Limb glutea of supported side. There is the opposite unsupported side of pelvis like a fulcrum. If abductor's mechanism is defective, the unsupported side, that is actually the normal side of pelvis, drops, and this is known as positive Trendelenburg. Unsupported side is the normal side that is actually dropping. It is dropping on both the sides, you have bilateral. Okay, so this is positive Trendelenburg sign. Now you might understand this, you might feel good, fine. But now another point which I might add a bit over here, which is very important, and that is, we said, okay, these are the problems of gluteus medius and minimus. You said, okay, sir. Then I said that these are supplied as superior glute nerve. You said, fine, sir. When will this nerve be injured? Think about it. This positive sign, which we just discussed, positive sign will be found in which conditions? This positive sign will be seen when there is a nerve injury, okay, due to which there is muscle palsy, as we have just discussed. What other situations can lead to positive Trendelenburg sign? Think. This muscle, gluteus medius minimus, is crossing which joint? It is crossing hip joint. So when there is a problem in the hip joint, what problems can occur over there? Like simple dislocation can be there. Like example, fractures can be there. Like example, some necrosis going on. If the joint itself is quite stiff, then that muscle cannot work. Third condition over here, joint is formed by bone. So when there's a fracture of femur bone, you just imagine, like hip joint fractures, same as femur fracture, which I meant over there. So in bony fracture, in your joint arthritis, dislocation, all that, or in your typical nerve injury, you will get a positive Trendelenburg sign. Okay, this is what I wanted to stress a bit over here. Right? Okay, I hope this point is clear. So this is a clinical applied. You can write, you can test the muscles. I just said how to test this. Ask the patient to do the action against resistance. As simple as that. Okay, now some clinical questions over here. 50-year-old with injury to the glute region has difficulty in walking on forceful steps. There is deviation of glute region. Trendelenburg test is positive. You know which nerve they're talking of, superior gluteal nerve. Let us try to do some MCQs over here. Okay, here goes the first one, that which muscle is not under cover of gluteus maximus? Yeah, try to think about the answer. Piriformis, was it under cover? Quadratus humerus, sartorius, and obturator internus with two gemini. I guess all these muscles you already have discussed. These are the 7 muscles, which is not a sartorius, it is present anteriorly. That will be the answer. Second question, IM injection, upper and lateral quadrant of the glute region are given in. Here we have gluteus maximus and minimus, gluteus medius, gluteus maximus. Obviously, it was what? It was gluteus medius, or if can correct this option like gluteus medius and minimus, it will be the best option. If we correct this, because it is basically going into gluteus medius mainly and also into minimus. But yes, you got the point. Lurching gait is due to paralysis of which muscles? Lurching gait is, we have just seen, it is gluteus medius and, okay, again, no worries, it is gluteus medius and minimus. Okay, so here option A, here we can, if don't want to edit that, then we can simply go to gluteus medius, or you want to edit medius and minimus, that is also fine. So it definitely goes into gluteus medius, and it's a bit deep, it will go to gluteus minimus, because minimus was the deep to the medius. Then we have another question, what is the origin of piriformis? Origin of piriformis is where it is from the upper sacral vertebrae. From there it comes. Okay, so we have these options, answers over here. Okay, so this was all about it. Now come to the back of thigh. Gluteal region, we discussed a bit detail. Back of thigh muscles, we already discussed in the beginning that there was a mnemonic which we discussed, guys. If you guys remember, there was a mnemonic that we discussed that was map of Sikkim, right? A map of Sikkim. Medial compartment, operator nerve. Anterior compartment, femoral nerve. This posterior compartment over here, which nerve? Sciatic. So the nerve over here will be basically sciatic nerve, and more specifically, the main branch which supplies over here is the tibial nerve. Though sciatic is basically composed of tibial and common peroneal nerve. Common peroneal nerve will also supply a small muscle, but the main nerve of the posterior thigh will be the tibial nerve, as we'll see. So those are hamstring muscles, and tibial part of sciatic will be the main. So these can be a question, name the hamstring muscles. Again, about the muscles, biceps hamstring. Okay, so again, as the muscles come, and you know what to write these 4 or 5 things over here. Basically, origin, insertion, innervation, action, and a bit of blood supply. Blood supply is plus or minus. Remember, all these posterior thigh muscles, they are basically coming around the ischial tuberosity. Ischial tuberosity. Okay. And where they are going below, they are not inserting mainly into the femur, but they are basically into the leg bones. Leg bones, I mean tibia and fibula, T/F, tibia fibula. Understand this? So these muscles, basically the 3-4 muscles, semitendinosus, semimembranosus, and biceps femoris. 3 major muscles. Biceps will have 2 heads. And you also have a hamstring part of adductor magnus too. But these muscles go down, basically these 3, which I'm saying the above 3 names. They'll basically go down, insert into the one of the leg bones, either tibia or fibula. Just think, understand. Now let me highlight over here. So this one muscle over here is semitendinosus, and the other you can see semimembranosus. Now see the name, semitendinosus. And how I will show you also in the diagram. See, this muscle is half tendon. So there will be a muscle belly, but as you go down, there will be thin muscle tendon. And this muscle membranosus will be slightly kind of wider than the tendinosus. So basically, membranosus is deep, and overlying the membranosus, we have the semitendinosus. Okay. So as said already, they come from the ischial tuberosity, as you can see, and they are going into the leg bones. These 2 go to tibia. They are innervated by the tibial nerve, and they basically helps in flexion of the flexion of our knee joint over here. The flexes leg. Flexes leg, when we say, we basically mean flexes knee. There's also one more confusion might arise. Let me clear that. When we say flexes leg, we mean flexes knee. Extend thigh is extend thigh, or you can say extend what? Extend the hip. Understand the small change of the meanings of word over here. So this semitendinosus, membranosus. Semitendinosus, if you want to add, you can also add. It forms one of the tendons of pes and serinus. It forms one of the tendons of pes and serinus. Pes and serinus might come as a question. It has mainly 3 muscles. It has the gracilis. Okay. Then it has semitendinosus. And on one side, it will also have the sartorius. These are 3 muscles. Why they are known as pes and serinus? Because they insert very closely, where in the medial condyle of tibia. Okay, so they are known as pes and serinus. Okay, fair enough. So we saw a bit of semitendinosus and semimembranosus. As you go down, look at the biceps femoris. It has 2 heads, biceps. No? So you have a long and a short head. The only exception over here is the long head, you have the tibial nerve, but the short head is supplied by that conperoneal nerve. Okay, that's the whole thing. Other thing which you should note over here is that semitendinosus and membranosus, while they were both going to tibia, this will go to where? This will go to the fibula. This goes to the fibula. Okay, this thing you should remember, right? Then, as I told, okay, we would have some hybrid muscle adductor mechanism as well, as discussed already, and we already dealt with it. Where will it insert and where does it take origin from? That we already done. Okay. Fair enough. These are all the muscles of the back of thigh. So let us highlight them again. So over here you can see the bulk of gluteus maximus muscle. You see these are the back of thigh muscles over here. The one that is going laterally is biceps femoris. Laterally means into the fibula over here. F for fibula. The other ones over here, like semitendinosus and deep, you can see semimembranosus. Just focus on these two muscles, which two? Semitendinosus and semimembranosus, which is deeper, which is superficial. And both are going where? Into this part known as medial condyle of tibia. So what they are doing is they're basically crossing the knee joint. So once they contract, there will be flexion of knee. There's going to be flexion of knee, and they might also assist gluteus maximus in extension of the hip joint or extension of thigh. Okay, fair enough. Let's move to a very important part over there. That is the sciatic nerve. Sciatic nerve is the largest branch of lumbosacral plexus. It's the thickest nerve in the body. Thickest nerve is sciatic nerve. Basically, what happens is that this nerve over here is a combination of two nerves. So there are two nerves inside it, as you just mentioned, that these two nerves are the tibial nerve and the common peroneal. There are two nerves inside one common sheath. That is known as sciatic nerve. If you remember the course, it passed below piriformis and it was under cover of gluteus maximus. This thing we know. Let's see more. So, if a question comes of sciatic nerve, start with it's okay. It's the thickest nerve in the body. Fair enough. It is the largest branch of sacral plexus. Fair enough. Root value is from L4 to S3. L4, L5, S1, S2, S3. Okay. Extent is rises from the pelvis and ends in the popliteal fossa. Now, how does it end? See, ends meaning by that it bifurcates into these two nerves. So it bifurcates into the tibial nerve and a common peroneal nerve. And this is the sciatic nerve. This common peroneal nerve goes laterally winding around fibula. A tibia goes directly posteriorly, back region only. So it's lateral and medial. Understand this. How is it formed? This now course. Remember, course is very important. Why? Because sciatic as the nerve, the problem might come from sciatica, as you might have heard of sciatica. Problem sciatica, pathology sciatica is common, quite common. So let's start. So lies in the course in pelvis, lies in front of piriformis under cover of its fascia. In the gluteal region, it passes through greater sciatic foramen below piriformis. These things, see, one you're writing as an essay, one you're writing as an arrows, giving like a flow chart. These things, they do help. They have a good, very good presentation. And this, in theory, it's going to be very helpful. Then they run down, it's like convexity. The trochanter, they passes behind the ischial tuberosity and the greater trochanter, popliteal fossa. As we discussed, they divide into the tibial and common peroneal nerves. Okay. Now, sciatic nerve course and relations, you can see over here. They are trying to show, and you can just simply make a posterior, the femur, and you can just show a nerve coming down, thick nerve. And just remember, as I told in the first lecture, in anatomy, the diagram, the beauty of the diagram, they don't need the beautification of the diagram, but logically it should be correct. So if you are making any sort of this diagram, just try to make a thick nerve, try to make the femur, which is going out like this, right? And then femur shaft and all at the coming, you have the condyle, so you medially draw tibia, laterally draw fibula. Okay, that is very important. Then you have to show the sciatic nerve coming down. It is innervating the muscles over here. Then as it is coming down at the popliteal region, you need to show the two branches. You need to show the bifurcation of sciatic nerve. That is important. Because whatever you have written, you can convert that into a diagram over here. This diagram will also easily work. See, so simple. What are the key features in this diagram? Try to learn from everything, guys. Whatever you're seeing, key feature is the person has made the piriformis, and below this person is showing the sciatic nerve. Then from here, they are showing the branches coming out. And what's the beauty of it? That they have written the name of the muscles which the tibial nerve supplies, and short head of biceps femoris supplying which conperoneal nerve. The beauty over here also lies, see, this nerve, they have made two different color. One is the yellow color over here, okay, and one over here is the green color. You can very well see the green color is the tibial nerve and the yellow color is what? Is the conperoneal. And all the major muscles supplied by tibial nerve, only this exception over here supplied by the conperoneal. And similarly, this shortened biceps femoris, earlier it's used to come as a MCQ. Nowadays, not coming from few years, but earlier it used to come as an MCQ, that which is a true hamstring, which is a pseudo hamstring. So all these muscles over here, basically these three muscles over here, they are regarded as a true hamstrings. Why? Because hamstring muscles, they are supplied by tibial part of sciatic. And the other feature of hamstring was what? So one feature of hamstring is, let me write over here, that they're supplied by tibial nerve. Another feature of hamstring was that these muscles, they come from the ischium or ischial tuberosity, to be more precise. The third component of a true hamstring was that it has to go into one of the leg bones. Now, this biceps femoris over here, it is considered as a pseudo hamstring. What is considered as a pseudo hamstring? Why? Because you can see the point. It is not supplied by tibial, it is supplied to common peroneal nerve. It is not coming from the ischial tuberosity, it is coming from the femur. Yes. This shorted biceps femoris is coming from the femur, not from the ischial tuberosity. Therefore, these were the earlier questions. So do remember this simple diagram also you can make, that will fetch you marks. Now, relations, there are 2-3 relations over here which I will focus more on. Try to understand that. About the sciatic nerve. Sciatic nerve is quite a superficial nerve, but there will be 2-3 structures which are superficial to sciatic nerve. One we already have seen. What? One was that gluteus maximus muscle in the gluteal region. A very good MCQ came few years back. That MCQ was in the thigh region. In the thigh region, because sciatic is up till thigh only, no? Below thigh, it will divide into 2 branches. So in the thigh region, which structure is crossing the sciatic nerve? Thigh, not gluteal region. So in the thigh region, as you see down over here, the only this long head of biceps femoris muscle, that is the one that is crossing the sciatic. That is the point. Let me show you above if there's some image over here, or it might be somewhere below also. Let us see. Okay. So these are the 2 things that you need to know, right? Deep or anti or deep to this muscle, deep to this nerve, there are a lot of structures. You can just go through them. Not a big deal, but superficially. Why? Because suppose you are removing the gluteus maximus, you need to be sure that you don't damage the sciatic nerve. Then branches, obviously, articular branches. It's the trick in writing is not saying branches 1, 2, 3, 4. Branches, subpart articular branches to some joints over here. Then muscular branches. Then right tibial and common peroneal. Then obviously, clinical anatomy will always fetch you 1 or 2 marks extra. If they have, see, nowadays normally the examiners, they ask specifically, if it's a 10-number question, last 2 marks will be for the clinical anatomy. But if there is not like that, even then write up 1 or 2 clinical anatomy of any topic. So how to test it? Okay, test a hamstring again, as I said already. Action against resistance. Sleeping foot, obviously, when a person sits on the edge, sciatic nerve might be compressed. There will be numbness, or it's a mixed nerve. Sciatica, we are discussing this already. Sciatica, and there's also semimembranosus. Bursitis can be there. Bursitis. Okay, the inflammation of the bursa known as bursitis. Okay, you can see over here piriformis, and this is a compressed sciatic nerve. As I told you initially, this a syndrome known as what? Piriformis entrapment syndrome. It's known as piriformis entrapment syndrome over here. Okay, this can be seen over here. Then you can simply make these diagrams for showing us the applied aspect. Okay, this is how you can make some muscles over here. Okay, and pass and here one more point, last one we can add is the anserine bursa over here. Anserine bursa, as I discussed, there are 3 major muscles which will come over here, and they are forming this bursa over here. These 3 major muscles. Can you understand the view? Which view is this? I'll just show you the diagram. Try to think which view is this. Look at the labeling. Semimembranosus is there, tibial collateral ligament is there. Can you see this bone over here? This is a patella over here. Okay. So what do we understand there? Okay, this is the anterior aspect, there is a posterior aspect. Okay, this is anterior. We are looking at a medial view of the left knee joint or left knee region. This is a medial view of the left knee region. Okay, so this is where the 3 muscles over here. Now, question might come. See, they might give you this area in the exam, and they might put an arrow over any muscle. They might ask you which muscle is this. So 3 muscle names I gave when we discussed the pes of pes and cellulus. That was sartorius. Okay, then there was gracilis, and then there was semitendinosus. Now we have done cover up the thigh. Now we should be knowing that which muscle is from which compartment. Sartorius is coming from the anterior compartment. Gracilis is from the medial compartment. Remember Goa, G. And semitendinosus from the posterior compartment. So most anterior tendon over here will be sartorius. Middle tendon will be G for gracilis. The posterior tendon over here will be semitendinosus. Because that is coming from posterior compartment. And then you have a bursa over here. Okay, yeah, that is a spas anserinus bursa. Okay, I hope they got the point. So that's the whole point. Now let us look at the MCQs. Posterior compartment, also known as flexor compartment, right? Simple as that. That is a flexor compartment. Abductor, if you know abductor, you have the medius minimus. Extensor is anterior compartment, and adductor is medial compartment. Biceps humerus inserted into, see, there comes a question, inserted into the fibula, head of upper end of fibula, head of fibula. And this is the reason, let me add over here, that once we talk of the action of biceps humerus, other muscles like semitendinosus, semimembranosus, they do what? They flex the knee, fine. But apart from flexion of the knee, they will also do medial rotation of the knee. But this biceps humerus, apart from flexion of the knee, it will do lateral rotation. Why? Because it is going to the lateral bone. Okay. Third question, compression of which nerve leads to numbness of lower limbs? It's the sciatic nerve that will do numbness of lower limb, right? Which is not a character of hamstring muscle. See, original ischial tuberosity, yes. No, nerve supply is by the tibial. So not over there, we can go with option number B over here. Okay, muscle acts as a flexor, insertion to yes. So the answer will be option number B. Likewise, these MCQs can come over here, right? So this was all about the gluteal region, posterior compartment of thigh. I hope you guys are enjoying. So that's all. And also, if we look back over here, then do remember all these features and subscription plans. Okay, and also remember to use the code also. So we have a code over here, that is Ankit 20 over here. You can use the code also for all these plans, as you can see already. Right, 4 features, remember, and next time we'll come with the other part of the our lower limb. That's all, guys. I hope you're enjoying. Follow us on social media handles over here, and that's all. Any queries? The comment box is over there. You can ask anything over there, right? That's all from my side. Bye bye. Good night, and have a nice day. Thank you.